Okay, well, hi everyone. My name is Dr. Sharanya Joginpalli, and I'm a pediatric rheumatologist with Child Neurology and Consultants of Austin. And I'm here today to do one of our first rheumatology doc talks on juvenile arthritis, helping kids stay active and thriving. Before I start, I just wanted to introduce my rheumatology nurse, Kayla Mulligan. You may see her around rheumatology clinic and communicating with you through the portal. So just wanted to introduce her before we get started.
Hi, everyone.
All right. So I'm just going to start with a brief agenda of what we're going to cover today. Just a brief introduction to what JIA is, what are the symptoms of arthritis and its complications, basics on JIA treatment, and then we'll go more in depth into what is an arthritis flare, how to manage an arthritis flare, what are lifestyle recommendations for typical JIA patients. That's including diet and physical activity recommendations. And then lastly, school accommodations that we do for our JIA patients. And then we'll end with questions and answers. So just starting off, JIA it was one of our most common diseases, and the Arthritis Foundation is a national organization that's played a big role in JIA. They've actually branched off to form a pediatric JIA foundation with the slogan Kids Get Arthritis Too, focusing on more juvenile arthritis. And just a fun fact, July is Juvenile Arthritis Awareness Month. So just going into a little bit about quick facts about JIA. It is the most common autoimmune disease that a pediatric rheumatologist diagnoses and treats. It was previously called JRA, Juvenile Rheumatoid Arthritis. The nomenclature changed almost a decade ago, since the juvenile version does not resemble what an adult rheumatoid arthritis looks like, hence why it went from juvenile rheumatoid arthritis to juvenile idiopathic arthritis. The diagnostic criteria for JIA requires the disease onset before the age of 16 years, persistent signs of arthritis in one or more joints for longer than 6 weeks duration, and then it must exclude any other causes of childhood arthritis. So it is a diagnosis of exclusion. Some more fast facts about JIA. The incidence is 1 child in every 1,000 that has juvenile arthritis. It can affect any type of joint or joints, and the most common age group we see this is between 1 to 5 years. Some subtypes of JIA can be seen more in the teenage years, but as a whole, JIA is seen more under the age of 5. Family history can be present, but it is not genetically inherited, and it can be triggered by certain infections. What are the signs and symptoms of JIA that you should look for in your child or for a new diagnosis? They should have joint pain in one or multiple joints, swelling in the joints, stiffness, which they may describe as being frozen or discomfort for at least 30 minutes up to an hour, and especially in the morning or after periods of inactivity, such as if they take a long nap, if they sit in a car ride in a car seat. They should feel warmth over their joint, pain on the joint, especially while moving or touching. They can have limitation of motion, meaning anytime they move their joint, it's hard to move it. Little kids may start limping when they can't bear weight on their right or their left leg, especially again after waking up after long periods of rest. Certain types of JIA can be accompanied by fevers and rashes. And then if we have complications of JIA, which we will talk about, called uveitis, they can present with eye pain, redness, and vision issues. They can also have long-term growth and development problems. So I just want to briefly show a photo of a joint and how it looks like, and then what happens in JIA. So the picture to the left shows the knee joint. So you have a bone on top, which is your femur, and the bone on the bottom, which is your tibia. And then inside is a typical knee joint. So on both sides, you have your cartilage, and then inside that cartilage, you have what's called a synovial membrane, and that provides nourishment to the joint. So it has all of the good, healthy vitamins, minerals, and fluid to help nourish the joint and keep it active and strong and moving. And then that yellow space inside is called a joint cavity, and that's what has your synovial fluid, which is the gel layer, the shock absorbent layer that helps kids when they're active and moving to prevent fractures and dislocations and keeps the joint from rubbing up against each other. The picture to the right that shows what a typical juvenile arthritis inflammation looks like inside the joint, you can see that that synovial membrane inside the joint, the black area, is all swollen and inflamed. So that's what's called synovitis, which we can see on MRI. And typically when synovitis gets really bad, it can actually cause a lot of fluid buildup, which is what's called an effusion, which is a swelling over the joint. And then it can actually cause destruction to the cartilage, which I'll show you in the next photo. So this is the same photo, except shown from a lateral side view of what's happening inside the joint. So if you look at the right side half of this photo, you see that that whole synovial membrane inside is inflamed, and it can overgrow and become enlarged, and that's what leads to big joints in little kids. And then in the first period of arthritis, you have a lot of synovitis and inflammation and fluid buildup in the joint, but then eventually all that fluid will resorb and go away to the point where you won't have any fluid anymore, and then you'll have narrowing of that joint space, much like what we see in osteoarthritis in older men and women. Eventually, that joint space is lost, and then you get bone on bone. And then bone on bone is very bad because it can cause what we call erosions, and that is late stage of arthritis. So how do we diagnose JIA? There's no specific laboratory test to diagnose JIA. It is solely based on a clinical exam. So what your child's symptoms are, what they are experiencing, what is the history that you tell us based on the signs and symptoms we discussed earlier, and then what we see on physical exam, if we see warmth over the joint, redness over the joint, swelling, stiffness, difficulty when we're trying to move the joint in the exam room, or if they have late stages, what we call like contractured joints where they don't move at all because of the tightness of the muscles and tendons around the joint. So JIA is purely a clinical diagnosis. Sometimes we will have labs that may show inflammation, or they may have arthritis antibodies like a rheumatoid factor or an ANA or a CCP or an HLA-B27. And those are all associated with different types of JIA, but it certainly does not diagnose a JIA if they are present or positive. Labs can be completely normal in JIA as well. Ultrasounds can show the effusions, which is the fluid in the joint. And MRIs are our diagnostic study of choice. They are the most detailed imaging to show us any acute changes of inflammation inside the joint, as well as chronic changes of inflammation, like the erosions. So they help us actually guide therapy, whether they are failing therapy or their JIA is flaring or they have good response to therapy and we think they're getting better, we may do interval MRI imaging. So what are the types of JIA? I briefly want to go over just the first three types because those are the most common that we see in this practice. The last two are less commonly diagnosed. The most common being the oligoarticular JIA, but here are the five types: oligoarticular JIA, polyarticular JIA, systemic onset JIA, enthesitis-related arthritis, which is known as ERA, and psoriatic JIA, which is associated with psoriasis. So oligoarticular JIA is our most common subtype of JIA. Up to 80% of children who have JIA have this type of JIA. The most commonly affected joint is the knee, but any and all joints can be affected, and usually the child is under the age of 5 at diagnosis. This type of JIA has the highest risk of eye inflammation called uveitis. With this type of JIA, there are no systemic symptoms, but over long term, because of complications of an untreated or underdiagnosed oligoarticular JIA, they can have growth disturbance. This type of JIA has very good outcome and response to therapy. Next is polyarticular JIA. So this is the second most common type of JIA. It affects 5 or more joints, unlike oligoarticular JIA, which was 4 joints or less. So polyarticular JIA will be those kids that have multiple small joints of the fingers and the toes and elbows, wrists, knees, and ankles at presentation. This JIA also has a risk of uveitis, but much less compared to oligoarticular JIA. For this specific type of JIA, the arthritis labs with the arthritis antibodies that we had talked about, the rheumatoid factor and the CCP antibody, actually help predict future disease. So if you have a very strong family history of rheumatoid arthritis and you have positive labs and antibodies in very high levels, that's usually a very good clinical predictor that that child may have more long-term chronic disease. In patients who are older 16 years of age at diagnosis and they present with polyarticular involvement, meaning more than 5 joints, they're actually called rheumatoid arthritis at that point, which is the adult rheumatoid arthritis equivalent. They are no longer called JIA due to their age. This type of JIA is harder to treat just because of the multiple joint involvement. So typical initial therapy is to just start immunosuppression right away because there's a lot of uncontrolled inflammation in multiple areas. And this type of JIA can cause a lot of complicated arthritis, such as joint contractures, loss of mobility, and deformity in the joints, even despite treatment. And then lastly, systemic JIA is the third most common type of JIA, and this can affect any number of joints and any type of joint. The diagnosis is a little bit different. So previous two subtypes required at least a 6-week history or longer of joint symptoms, but this systemic JIA only requires a 2-week history of daily fevers with evidence of arthritis and at least one additional systemic symptom, such as the typical rash, enlarged lymph nodes, enlarged liver or spleen, and inflammation around the heart or the lungs, which is what we call serositis. So because of the systemic involvement with the arthritis, this type of JIA is very different than the others. The labs on initial diagnosis will show very high inflammatory markers and blood cell abnormalities, and occasionally liver dysfunction as well. The initial treatment for this is steroids to immediately decrease the amount of systemic inflammation. This, again, is a diagnosis of exclusion in any child that is presenting with recurrent fevers. So we must rule out any type of acute or chronic infection or malignancy. So what are the complications of JIA? The biggest, most common complication are joint enlargement, so having those big solid effusions and joint swellings and joint contractures, difficulty walking or limping, limitation of activities, which is the biggest one that usually alerts parents when their child is less active or inactive compared to their normal, immobility, limb length difference, which is when one side grows bigger than the other, if one knee is affected more than the other one. Delayed growth, if they have a lot of joints involved over long term. If that inflammation is not controlled, then they will have poor growth and development. And then lastly, weight loss. When you have systemic inflammation that goes uncontrolled and undertreated, you can have weight loss. I just want to briefly talk about uveitis since it's very important to know what uveitis is in its relation to JIA. Uveitis is inflammation of the eye, and you can have anterior or posterior uveitis depending on if the front or the back of the eye is involved. Up to 20% of patients with JIA can develop uveitis at any time point during their disease, and it can be painless or painful. Oftentimes it is painless. Other symptoms you may see is eye redness and irritation, light sensitivity, eye pain, or blurry vision. So this is why when you have a diagnosis of JIA, we send you to ophthalmology to get screened regularly. And then the ophthalmologist decides how often you need screening based on age and your type of JIA, and also your ANA status, whether you're ANA positive or negative. Typical screening recommendations are every 3 months or 6 months or yearly. ANA positive patients have a much higher risk of uveitis than ANA negative patients. So now that we've talked about diagnosis and symptoms of JIA, I want to briefly touch upon treatment for JIA, which most of you may already know since you are taking this medication. And just knowing the different names of medication and the options we have to treat JIA, we have come a long way from how JIA was treated in the last 40 or 50 decades. So this is directly from the Arthritis Foundation. This is kind of their statement on treatments for JIA. There is no cure for JIA, but with early diagnosis and aggressive treatment, remission, meaning little or no disease activity or symptoms, is possible. So our goal is to get our patients into remission. It does not mean we've cured their arthritis or we take away their arthritis. Their immune system will still have the tendency to cause inflammation of the joints, but our hopes with treatment is to reduce all of that joint inflammation and reduce their symptoms so they live a normal, healthy life. The goals of JIA treatment are to slow down and stop inflammation to prevent disease progression, to relieve symptoms, control pain, and improve quality of life, to prevent or avoid any joint and organ damage, to preserve joint function and mobility for adulthood, and then to reduce the long-term health effects that JIA can cause. So what is the treatment of JIA? Steroids are a backbone of treatment for any autoimmune and autoinflammatory condition because they work very fast and they are very effective. Now, we don't like using them in long term simply because of the very severe and chronic side effects it can cause, especially when used at such a young age in children. So we like to do what's called intra-articular steroids, which are joint injections. When we have at least one, if not two joints, this treatment approach is easier because we can do it under sedation as an outpatient procedure, or there are some rheumatology offices and orthopedic offices that do it just as an outpatient procedure under local anesthesia. Now, this is if you only have one or two maximum joints involved. You can do an intra-articular steroid injection, and usually you should not have more than 3 injections in a year. Oral steroids work just as well if you have more joint involvement, usually at diagnosis when you have more of the polyarticular form of JIA and you have a lot of inflammation in multiple areas. Oral steroids work better either with prednisone, which is the tablet form, or prednisolone, which is the liquid form. We usually don't do it for a very long time because of the side effects. Other treatment options, and these are the ones that you all will be more familiar with. Our first-line treatment for JIA, based on our rheumatology consensus treatment protocol, is to start off with NSAIDs if you have oligoarticular JIA. So that would be either scheduled ibuprofen or naproxen at weight-based dose. Then if they have failed NSAIDs, or if you have more severe arthritis with multiple joints or not responding to NSAIDs, we use what's called DMARDs, which are disease-modifying anti-rheumatic drugs. So these are very, very old drugs they used to use back in the day that we still use a lot of them. And our go-to medication, which works great for joint inflammation, is methotrexate, which comes in tablet form, liquid form, or IV, and this is a once-weekly medication. Usually the more severe arthritis or treatment-resistant arthritis or polyarticular joint involvement usually requires the use of biologic therapy, and these are the brands that you have heard of, which are your TNF inhibitors, Humira, Enbrel, Remicade. You have other biologics like Cosentyx and Xeljanz. For your systemic JIA, you have Ilaris or anakinra, and these come in forms of pens, injectable pens, or infusions. So what is a disease flare? This is very important to know, especially if you're monitoring your child and monitoring response to therapy to see how they are doing. If they're in remission and they have no symptoms, that's great. If they are non-compliant with medication, or we've had medication, we just don't think it's working, then they may present as what we call a JIA flare. And this basically means that there is active and worsening inflammation in the joint or multiple joints. So symptoms of a flare are usually increasing joint pain, swelling, more stiffness, and activity limitation. Patients may also have fatigue, nausea, and fevers. These flares can occur during treatment, even if we're treated adequately. It can occur if there's inadequate treatment, like non-compliance to treatment, or even after stopping treatment, thinking we are in remission, and then we flare again because we need to go back on treatment. So it doesn't necessarily mean you're flaring because of improper treatment. Flares can happen if the immune system is just overactive and we did not get it under control well. So anytime you feel like your child is experiencing a JIA flare, please let your doctor or your care team know, because we need to treat that immediately. What causes a JIA flare? So the most common reason is missing medication. These medications are designed to be given either every day or every week or every 2 weeks or once a month. That frequency is designed based on the pharmacokinetic profile of that drug. So, for example, if you're not taking your methotrexate every week, the way methotrexate works as a good therapeutic effect is to work every single week for the drug to build up in your body. So missing doses of medication or giving late doses of medication can certainly cause flares. Other reasons are medication just simply not working, even though we're taking it. The biggest thing we see in pediatrics is an infection, an illness, or an injury that can incite a flare. Stress, whether it be emotional, physical, psychological stress, can cause the immune system to be overactive. Cold weather and weather changes, so typically JIA flares are more common during the winter time. trauma, any injury or surgery to the joint, excessive activity. So if those highly athletic teenagers who are in multiple competitive sports have overuse injury of the joint, they can cause a flare, lack of sleep, and then lastly, hormonal changes in puberty. So how do we manage a flare when it happens? So if it's due to medication being missed or being late, then we ask you to get back on schedule and take your medications at the appropriate dose. If we are taking our medications and we are still experiencing a flare, then for breakthrough pain, we will add on a week or two of scheduled ibuprofen or naproxen or topical Voltaren gel, which is diclofenac, which is also another NSAID. So all three of these NSAIDs are very good options to be done for a short period of time for breakthrough pain to calm down the inflammation. We may also prescribe, like I had said earlier, a short course of oral steroids if the flare symptoms are not improving. And then other non-medical things that we can do are applying warm compresses or heat pads to increase the blood flow to the joint and the muscles. And this basically reduces all of that joint stiffness and allows the joint and the muscles to relax. Some patients find even ice is better for acutely inflamed joints, much like sports injuries, to reduce any inflammation in the joint. And then lastly, basic things like rest and activity limitation. You don't want to overuse the joint when there's a lot of inflammation, getting adequate sleep, staying hydrated, and then informing the school for accommodations to have what's called a flare plan, which we will talk about in a bit. And this allows the school and the school nurse and parents to be on board to excuse the child for absences during a flare. So coming to a healthy lifestyle. So this is very, very important on top of taking your medications and then getting interval checkups is to make sure that you have a very healthy lifestyle, right? Because if we're not sleeping properly and we're not eating a healthy diet and we're not exercising, then all of that is going to cause a lot more stress as a whole. So healthy, balanced diet, getting at least 8 to 10 hours of sleep based on the sleep you need per your child's age. We have had great experience doing sleep referrals to our sleep center, which our clinic was thankful for having. We do in-house sleep studies now, so if you are ever wondering if your child needs a sleep assessment due to insomnia or sleep difficulties, please let us know. Exercise, so we work very closely with groups of physical therapists in Austin and all around Austin. So physical therapy is something we will talk about, but just keeping your child active, moving around those joints, because the last thing we want is for them to have a sedentary lifestyle where they're not moving the joints and they feel more stiffness. And then lastly, reducing stress as a whole, because that plays a major part in a lot of a child's health that parents may or may not realize. Healthy diet. So this is very, very important for just keeping good bone and joint health. So vitamin D and calcium are very, very good for joints. Vitamin D helps with nourishing the joint and mineralizing the joint and keeping the bone healthy. So most of our patients are on some sort of vitamin D and calcium supplementation, either it be a multivitamin or taking these two separately, especially if they're on chronic steroids, because steroids can cause demineralization of the bone and make it very weak, especially if we're taking it for a very long time. They will be on vitamin D and calcium supplementation. You can also get calcium through a variety of other ways, through diet, and then increasing protein intake. So having a very good amount of protein in your diet, and that is very good for muscles and building good, strong, healthy muscles, tendons, and ligaments, because those are the supporting structures around your joint. Physical therapy. So having supervised graded exercise program for individual patients is very important, especially at the onset of your JIA diagnosis. Physical therapy is what I highly recommend because it keeps the joint active and moving. In a graded program that they won't add extra stress on your joint. The type of therapy we prescribe really depends on the type of arthritis that you have and how many joints are involved. So having a home exercise regimen and a scheduled physical therapy session is very helpful. You can also use things like splints and bracing for extra joint support. The types of exercises we prescribe for physical therapy are strengthening exercises of the joint and the surrounding muscles, flexibility exercises to decrease that stiffness and increase mobility, range of motion exercises to prevent those long-term joint contractures. And overall, it just helps reduce pain. It maintains good joint function and strength. It reduces your risk of long-term injury, and then it improves your child's quality of life. Sports and physical activity. So these are very common questions that we usually get from parents, like, can my child continue to play sports? Is it okay to continue since they have this diagnosis? Overall, yes, it is okay for them to go back to their sports and extracurriculars and clubs. However, it's usually after a discussion with their rheumatologist. So at diagnosis, we have a temporary restriction from activities only because the joint itself is healing. So when a joint is healing, we don't want to add that extra stress on the joint apart from physical therapy because we're afraid that that inflammation won't heal as fast if you don't give the joint enough rest. After a period of about 3 to 4 months after getting started on medication and they go into remission, that's usually when we encourage them to be back to activity and healthiness. We also recommend avoiding contact sports because, again, there's a risk of joint injury. So depending on the sport, you can always talk to your rheumatologist and see which sport is okay for your child to participate in. Usually we provide a medical letter of accommodation, which discusses their disease, their type of JIA, their medication, and if there is at all any activity restriction. And this should be discussed with the school if it's school-related activity or the team coach, and it should be reviewed at the start of every season. Lastly, for sports and physical activities, all of these children need to be wearing proper footwear and protective gear, sunscreen if they're staying outside, and then staying hydrated as well to prevent dehydration. School accommodations. So this is something that is very important to us. Being rheumatologists who deal with chronic disease in children, but really any other specialist who deals with children who have chronic diseases and chronic illnesses. This is called a 504 plan. So a 504 plan is a federal plan, and it basically makes adjustments to the learning environment that help the student with disabilities participate in the general educational curriculum. So basically, any student with disabilities, a 504 plan is essential for them because it levels the educational playing field and it gives them all the resources that they need so that they can thrive at school. This 504 plan is reviewed annually by the school board, and it's reevaluated every 3 years or when needed. So if you have a change in diagnosis, if you have an additional medical diagnosis, it needs to be reevaluated. So typically we, as the primary providers, and the specialists, we will provide a 504 accommodation plan at diagnosis that highlights all of the accommodations your child needs to have in school. And this is at no cost to the parents. A 504 plan for JIA patients, what it typically looks like is extra time between classes, having extra test taking time, typing instead of handwriting if you have a lot of wrist and small joint arthritis, carrying an extra set of textbooks and class materials, having ergonomic school supplies like a wheelie backpack, elevator passes, longer bathroom breaks, visits to nurses for medications, being excused from PE and gym class if they have an arthritis flare, excused school absences when medically necessary, such as doctor's visits, hospitalizations, or labs. So these are all types of 504, general 504 accommodations that we have to provide. That brings us into an IEP plan. So what is an IEP plan? So an IEP plan is an individualized education plan. This is also a federal plan for children with disabilities. I'm just going to turn my light on 1 second. Okay, sorry. I had not realized that my light was not on. So an IEP plan requires a conjoint meeting between parents, teachers, and the school administration, along with the physician's supportive documentation of the child's condition. So as long as the physician clearly declares that this child has JIA and this is the treatment plan and we need an individualized curriculum for this patient, the school board mandatorily needs to make an individualized education plan for your child. And this again provides learning accommodations, and that includes modification to the curriculum. So it's a little bit different than a 504. I always think of a 504 plan as more of physical accommodations versus an IEP plan is more of curriculum modifications and learning modifications. So examples of IEP accommodations are specialized tutoring, using assisted technology, laptops, voice recorders, modified exams and assignments, flexibility in the school schedule, so having breaks between classes, allowing rest breaks, and excused absences from the school. It also incorporates any prescribed medical therapies into the school time. So having physical therapy or occupational therapy or speech therapy during school, and then also having access to specialized equipment such as hand splints, knee braces, if they are needed during the school hours. Teachers are often trained on understanding what JIA is and its impact on learning. So schools who have very good IEP school accommodations and the school board is very strong, oftentimes they will have teacher training on different diseases and different medications. So they're more familiar what their student has in their class. They also implement what's called a flare-up plan, and this is a standardized plan drawn up by you, your parents, and your doctor, that's presented to the school, and it's when your child has a flare, if there's a sudden change in your child's health, the school must follow this flare-up plan to oblige if the student needs to urgently go to the hospital or need to get labs or need to get medication from the school nurse or go home early, be excused from sports practices, things like that. Again, IEP plans are just like 504 plans. They must be renewed and updated annually, or if there's any change in the child's health status. And again, this is no cost to the parents, so we help do an IEP school accommodation if you need it. Okay. So lastly, I just want to touch a little bit upon what is the prognosis of JIA. So in the past, when JIA was very prevalent in the 50s, 60s, 70s, we did not have a lot of this new biologic therapy and medication that we have now. So diagnosis of JIA then meant a very poor outcome. A lot of our patients were, bedridden, in a wheelchair, on crutches. They had a lot of the joint complications, immobility, and growth and development issues. Now, JIA has a very good outcome because we have had such good medical advances in the field of rheumatology through clinical research and medical management. So all of our types of JIA have very good prognosis with early disease management and aggressive treatment. The oligoarticular JIA subtype actually has the best outcome. What causes a poor outcome in some of our patients? Unfortunately, those who have diagnosis delay. So if they present late to a rheumatologist or anyone who, could not unfortunately pick up on arthritis and get to being treated. If they have polyarticular joint involvement, meaning they have multiple joints involved that are very hard to control. If they have a delay in getting to biological or DMARD therapy, so if they've just been on NSAIDs for a very long time and they haven't gotten to what I call our fancy medication, that usually causes a worse outcome. The types of joints, so our high-risk joints are the ankle, the wrist, and the cervical spine, which is the back of the neck. So these three areas are very high-risk arthritis, and usually if they have arthritis in any of these three areas, we start intensive treatment immediately. And then lastly, if they have any of these arthritis markers like rheumatoid factor or CCP, with very minimal joint symptoms or very obvious arthritis in multiple joints, they usually have a poor outcome requiring treatment for very long periods of time. And I just want to finish off talking about the Arthritis Foundation because I think it's a very good resource for patients, children, teenagers, parents, relatives, friends, anyone who supports a child or someone you know with juvenile arthritis. It's a very good resource to have. It's a nonprofit organization that supports people with arthritis, both pediatric juvenile arthritis and adult arthritis. Their mission is to find a cure for arthritis and improve the quality of life for people affected by it. It was first founded in 1948, and then shortly after, they designated May as Arthritis Month, which is different than July, which is Juvenile Arthritis Month. So we have local, state, and national branches. So you can go online to find Arthritis Foundation and find your local chapter. We have the Texas and Gulf Coast for our state organization, and then nationally. So what the Arthritis Foundation supports is all of these patient and family support groups. It supports JIA education for everyone, even healthcare professionals. We have our own Arthritis Foundation group. It has social media pages, awareness events, annual walks. A lot of kids can apply to get educational scholarships for college. If they are a juvenile arthritis patient, they can apply for scholarship funding. It is very big on clinical research trials, and funding trials as well. And then lastly, just patient advocacy. So fighting for our patients, fighting for treatment, health and healthcare policies, and legislation. We will be sending out soon messages to all of you regarding this, but we do have our annual arthritis walk coming up, sponsored by the Arthritis Foundation. So every city has an arthritis walk. The arthritis walk this year is on May 17th, starting at 9 a.m. So we'll be forming a team, hopefully, for CNNCA. But if you guys are interested, then you can always go online and just sign up for our team, or just sign up individually and bring your family and friends to walk for awareness of arthritis. Well, I just wanted to thank you all for listening to this presentation. I hope it was informative to talk about JIA and what JIA is, how we treat JIA, how to stay healthy with JIA, that you can talk to your kids about and make sure um, they're they're being treated properly and they live a normal, healthy life like they should. Thank you for giving me this time. And if you have any questions, you can always reach out to us. You can go to our website or find us on the portal and reach out to me or Kayla. Thank you.